mitral valve diseases, which is mitral regurg, prolapse, and stenosis, although there are many more. These are the major three. So let's get started. One thing you have to know, first of all, in mitral valve disease, the annulus is a fibrous structure that's very important for good coaptation. It should be nice and firm. It shouldn't be loosened, because if it's loosened, the mitral valve leaflet can go on an excursion. In this ultrasound, you notice the aortic, the tricuspid valve is closed, yet the mitral valve is open. This annulus is mitral valve. So we have the this is a parasternal long axis view. So if you have the left atrium and it's going back here, since both leaflets are failed, this would be you would get an linear jet flow rather than a lateral or eccentric jet flow. And I like to teach this way because in the real world, you got to be able to diagnose with echo, which is the gold standard for diagnosing mitral valve disease, but also in general, just memorizing rote facts and then not being able to apply it in real life is not how you learn. So anyways, so this type of regurg, it's not called left atrial regurg because technically the left atrium regurgitation doesn't exist as a disease entity. We'll learn more about that as we move on, but this would be a just a mitral valve regurg. You can see the left ventricle appears a bit enlarged, and I'm not sure what the cause is, but you can see this is not normal. The atrial ventricular valves should open and close simultaneously with good coaptation in the healthy heart. Okay, so this just shows a video of how the regurgitation occurs. It's not any type in particular, but you can see basically the left atria is predisposed to enlargement and AFib formation, and some major structures to consider would be the cordoni tendineae and the cord muscle, because these two anatomical structures are usually, most instances, are what cause a leaflet to fail and produce mitral regurg. And that's why I was saying is there's no left atrium regurg, because the regurg occurs as a failure of the mitral valves, for instance, cord prolapse. So their regurgitation is going into the left atrium, but there is one weird type of regurg where the regurg goes from the left atrium into the left ventricle, but it's not atrial regurg because it's not going back to the atrium, it's going into the left ventricle. So that actually makes sense why that does not exist. So treatment is diuretics in elderly people. First of all, before we do this slide, let's look at regurgitate. Well, no, let's do this slide. Okay, so you can do a balloon catheter mitral valve replacement using either xenograft or allogenic transplant, which lasts 10 to 12 years, has to be replaced every 10 to 12 years. Surgical angioplasty lasts longer, and you can see here what the surgeon does is inserts a annuloplasty ring. So if your prolapse is caused by a weakened annulus ring, you would repair it like this. This is considered a complete annuloplasty. So it's usually got, so imagine you have a normal annulus that's nice and taut, but the regurg is caused by an MI with chordal rupture. In that case, you would have to do emergency valve repair, because if your cord ruptures, you're gonna the leaflets will fail completely, and there will be no there would be so much regurgitating blood by the leaflets being flailed that this would be the option. You could do a surgical replacement, I suppose, as well. I'm not a cardiologist. I'm not sure the timeline of that after a posterior infarct. I don't see why not. If you're getting, if you're in a hospital setting and you might get put on an ECMO machine, or so I'm just teaching this at my level of knowledge, but you could do either one. Yeah, so that's the surgical treatment options. Now here you can see this damaged valve leaflet is due to a coordinate tendinae transection. So what the surgeon does is he probably reconnects that coordinate tendinae, but he also, he tightens the annulus, because actually I think the annuloplasty ring is, because if you have regurg, by definition, you would have to have a weak annulus, even if the cause is due to coordinate tendinae rupture, because that coordinate tendinae rupture would not occur if you had good coaptation with each closure. And if you don't have good coaptation, which is the nice smooth closing of the valve, you're going to have leaflet excursion, which just means it doesn't close tightly. And that means if you have a leaflet excursion, that means the annular ring has stretched and not become as tight. And if it's due to other reasons, the annular ring could become too fibrous, but that's going into too much detail. Now, before we get going, let's just do real quick basics. This is the apical apical 2 chamber top left. Apical 4 chamber is top right. Parasternal long axis here, and suprasternal apical view of the mitral valve. So it just make it easy, I'll just give you the answers here. So that's the mitral. Here's the mitral valve here, closed in relaxation phase with good coaptation. Here's the mitral valve here, and the left atrium is here. Because it's apical, because you're looking from the apex of the heart, which is here, you see the left ventricle here, and the left atrium is at the bottom. This is parasternal long axis. I'm not sure if this has a disease because of all of this. That's a bad picture of a parasternal long axis, but it also gives you the pericardium, so you can rule out some other differentials. This descending aorta is, we know that this was taken in diastole because the descending aorta has a small diameter. So if it's in diastole, the valves should be closed, but it's tough to decide from this image. And then this is the suprasternal notch where, and that makes sense because if you're looking suprasternal, it makes sense that what you see is the left atrium and the mitral valve, right? And again, here too, you can see the pericardium. So, you could rule out pericarditis, tamponade or effusion. So this is just 2-chamber view. So in the 2-chamber view, the descending thoracic aorta is linear, transverse, but in the lateral apical long parasternal axis view, it's a circle because of the different visualizations. This is just normal. I mean, mitral valve there looks a little like not completely coaptate, but it's just normal. And then you see in the 2-chamber view, you see the abdominal aorta, which is really important because to know that you're not you get an image beneath the diaphragm. So when you're looking from the left ventricular apex, it makes complete sense because the left ventricle is orientated anterior to the right ventricle. So this has to be the lateral wall of the heart, and don't get it confused with the four-chamber view, where in a four-chamber view, this would be the right ventricle, right? So you see the lateral wall of the heart. You see the left atrial appendage, the left that would have to be the aortic valve there. It doesn't say, but it so the mediastinum, the heart is within the mediastinum, covered with a pleura, which we call the pleura with a fluid in between an imaginary space. The what do we call that? God, yeah. Oh, pericardium separates the mediastinal from the peritoneal cavity. Apparently, that makes very good sense, because if you think about it, there's your heart, here's your lungs, here's your diaphragm, and we know when you breathe in, the diaphragm contracts. So you can see that, and since this is an inaccurate, obviously very poor drawing, but since the left side of the heart is anterior, that makes sense why this left ventricular posterior wall is lined up with the diaphragm, because it's more like this. See, there's the diaphragm, and that's why you learn something new every day just by talking to yourself. It has to be true based on that reasoning. Okay, peristernal long axis, a lot easier to interpret than the two-chamber. So basically, the probe is the ultrasound probe is coming from here. Okay. You got the left ventricular outflow tract through the tricuspid aortic valve. Why they're called semilunar valves, I don't know why. Well, I guess even if the aortic valve, the normal, it has 3 leaflets, I guess semilunar just means it looks like a moon or something. So if you draw the valves, it's semilunar, whatever, it doesn't matter. Right ventricle, you don't see the right atrium. Here's the mitral valve leaflet. Here's the mitral valve leaflet. Let's see. And the ascending aorta is open. We know this is in systole. And see how I said the descending thoracic aorta? See how it's bigger than in the previous picture in diameter? That's because it's taking the cardiac output to oxygenate the tissues. So this here, you see posterior medial papillary muscles. So the papillary muscle posterior medial, yeah, that makes perfect sense. Because the papillary muscles are located posterior, and you'll learn why a posterior coronary artery infarct can cause papillary muscle rupture, as that they are supplied by that coronary artery, and that causes massive mitral valve regurg, because just complete disconnection from the strings, and pericardium looks normal. Coronary sinus is there. Right coronary cusp. It's right. What's the right coronary? Right coronary. Right coronary cusp. So, in a non-coronary cusp. Remember, it's important to know that the heart needs oxygen itself. Just because it provides oxygen to the whole body, let's not forget it needs its own heart. So the way it gets that is through the right coronary cusp, which turns into the coronary arteries, and during diastole they fill, and during systole they contract and oxygenate the heart tissue. Okay, so that's the peristernal long axis. Okay, let's move on to our first, I believe, our first pathology. So we have the mitral valve there in a four chamber apical view, and the tricuspid valve is opening and closing at the same time, but something's wrong here. A flail cord. It said the answer right there. And what's a flail cord? I like to tell people that anytime you're not sure what a medical terminology means, think about a flail cord. So we know that the leaflet is attached by coordinate tendoni. So we know that the leaflet is damaged due to a flail coordinate tendoni. And this is classically called, so the, I'm going to try to pause it at just the right moment. And transdoppler also very important to assess the severity of the regurg. Anything less than 30 is mild regurg. Anything over 60 mils back is severe regurg that probably requires surgery with replacement or repair, depending on many factors. But so you, flail cord. Yeah, so see, because this is often described as a parachute string, like the mitral valve is like a parachute string. If you lose the cordoni tendineae is like the strings on the parachute, and what happens if you lose a string, the leaflet goes into excursion, which means simply it doesn't coapt like it should. It because you don't have that cordoni tendineae to keep it from stopping from moving forward. And in this case, what you would have is a eccentric jet flow regurg going opposite of the diseased leaflet. If both leaflets were diseased, you would get a central flow as normal in the regurg process. Like that. Okay. So Carpenter's classification, type 1 is normal for, unless you're a cardiologist, type 1 is normal. There is one type of regurg in type 1 that's considered pathological, but that's cardiac pathologist, cardiologist stuff. Type 2, and what before I explain these three types, what's important to know is you want to know the way the leaflets are damaged and correlate them to the Doppler color ultrasound. And this is what I mean by, because you're diagnosing it with an echo, right? So let's look at type 2. Type 2 is excess leaflet motion, as we can see here. Now let's think, we just talked about flail cord. That can cause excess leaflet motion. So, but you could get excess leaflet motion from a papillary muscle rupture, a weakened annulus, because the annulus is what allows for good coaptation, and you see how the regurg is eccentric jet. And so let's say it's type 2 is usually caused by papillary rupture or cordoni tendineae rupture. And typically it affects one leaflet, apparently. And to go to the Doppler ultrasound, if we know it's a type 2, then we're going to be looking for the jet flow. We're going to want to make sure it's lateral. We're going to want to see some excursion of a damaged leaflet, right? Type 3A are caused by restricted leaflet motion. So this, like rheumatic heart disease, it's like, generally think about it, it's stiffened, or calcification, so it's stiffened. And the big keyword here is opening snap. And you gotta, there's, the opening snap is tricky You should always memorize the opening snap with type 3A mitral regurg. But the snap you hear on stethoscope is actually when the valve closes, not when it opens, because common sense tells you that the left ventricle, the left atrium has a lot less pressure than the left ventricle. So you'd think that the opening snap is heard because the left atria is struggling to open those restricted leaflets, and once it pops them open, you hear the opening snap, but that's not it. It's when they close back. So it's a misnomer. So here you see the aortic or the tricuspid valve. Let's see, yeah. Tricuspid valve is closed and the mitral valve is open, so we know it's regurgitation because they should be closed and open simultaneously. Yeah, so that's the biggest way. If you see one valve open and one valve closed, think valvular disease. Type 3B is caused by leaflet motion defect during diastole only due to an enlargement of the left atrium, the left ventricle, sorry. So only during diastole. So what kind of disease would cause only diastolic mitral valve prolapse? And that is caused by congestive heart failure and when you think about it, I'm drawing some cordoni tendini and then papillary muscles. When you think about it, once the left atria enlarges enough but the tendini don't stretch out, the papillary muscles don't stretch out, so it's hard for during diastole when the left atria is pushing blood into the left ventricle. What happens is the opening of the valve is fine, but because the length of the cordoni tendini and papillary muscle remain the same, but the diameter from posterior to anterior enlarged, it's hard for those leaflets to close, for both of them to close during diastole. So you get eccentric jet flow into the left atria, and of course, again, can risk atrial enlargement, and then eventually pulmonary edema, and then right heart failure, and so forth. So that's the classifications of the different types of regurges. Let's try to move on a little quicker here because we still have prolapse and stenosis to go right now. So what's here? What do we see here? First of all, it's apical 4-chamber view. And the answer says it right there. It's leaflet structure and coaptation. And here, what you see here is a posterior coronary artery myocardial infarct, a very severe one, because look at how, I mean, these leaflets they're not going on an excursion. They're going on a 2-week vacation. I mean, it's literally hitting the interventricular septum. That's how bad. Uh, I mean, you pause it here, uh, and um, during systole here. Uh, Wait, hold on. During, so let's see here. Okay, so the color Doppler helps. You see all the blue going out? Like you can just tell that's more than 60%. So remember on the color Doppler, uh, the blue at the bottom, don't confuse it with venous blood. The blue is arterial blood. So when you see all that blue going from the left ventricle back into the left atria, that's arterial blood, even though it's blue. So you can see it's severe regurgitation due to PCA infarct, but and it happens. This would be a type 2 regurg, because remember, type 2 is excess leaflet motion due to papillary muscle rupture, which is what happens in a severe PCA. And so this has to be, see, you get confused. They're open, but you're in diastole, and that makes sense. That makes sense because if you have this severe of a disease, this left atrium is huge, and it's in diastole filling, but the leaflets are essentially floppy. They're not connected to anything because the papillary muscles has ruptured. So during diastole, because the pressure the pressure in the left ventricle during diastole is low, so you just get left atrial going. It's going straight to the left V during diastole. It doesn't need to wait for the leaflets to open because they're so floppy that as the blood fills, it just goes right into the left atrium, and you're not going to get, that doesn't mean you're going to get good cardiac output because you got the papillary muscle rupture. So I mean, these could go on an excursion here. They're not going to be nice and taut. They're not going to close. And we know it's diastole. Let me catch it. Oh. Yeah, see here it's closed, but the tricuspid is... Oh, ooh, this is an interesting one. Huh. Well, I just know this is a... Oh, I was looking at... This is the posterior infarct. Yeah, I didn't get a chance to edit the part out. Yeah, this is the posterior infarct. So this is where it's better to catch. Okay, here we go. We caught it. Diagnosis. We caught it. You see the tricuspid valve is closed. The mitral valve is open. Um, Yep, so that's why it's definitive diagnosis. And to prove it further, the color Doppler will show up. And you'll see all this blue stuff going right back into the left atrium because the leaflets are just, they're not connected to anything. Like it's almost all blue. Like look at that. That is some severe prolapse. Uh, here, this we have, this just shows the annulus size is about 5 centimeters normal. And if it stretches out over that length, that's what causes disease. And this is actually diseased heart. Here we have vegetations. You can just see it right there. It's obvious. If you can't see it, you shouldn't be a doctor. This is regurg due to vegetations. This shows good cooptation, but we know this is what type? This is type 3B due to left ventricular dilation. And this is the opening snap one. Because only during diastole, the leaflets have a hard time closing because after systole, they have to coapt, but the chordinae and the papillary muscles haven't changed. So, yeah. Okay, so that's it for regurgitation. Let's try to go on to prolapse. Despite the precarious nomenclature, this prolapse simply means that one leaflet does not close properly. It can progress. You want to treat it with slowing the heart and increasing preload and increasing diastolic filling time because it's usually mild and like you see here, this is the leaflet here that's a little prolapsed. The thing is, but imagine if you increase diastole. So this is a normal, this is a perfect coaptation of mitral. But imagine why that works is because it might push the non-affected valve a little closer, but here you would have a eccentric jet flow without much. It would be less than 30 mils of regurg. It's not very severe, but it can progress as the leaflet can get worse. It'll go on more and more excursions until it goes on vacation. And then you need a valve repair. That's why medical management is good with some beta blocker if you increase the ventricular size, it'll kind of like sort of help it stay sort of keep it at bay by lowering the opening. Because if it's small, this is if it's a small opening, eventually you're going to get bigger. The normal valve here during diastole, you can see it just, yeah, just normal open mitral valve. Let's move on. Okay. Okay. Where were we? We're here. So let's diagnose. Echocardium is the what? The gold standard diagnosis of mitral valve disease. Okay, I'm tricky here because this slide I misappropriated, so this is not a prolapse. Give you a hint. I didn't set it in order. First of all, you identified that this is parasternal long axis view. Let's give it a play. This is regurg. I accidentally put an example of a regurg in the type 3A regurg. Right there, you can see it. And you see the tricuspid valve is closed while the mitral valve leaflets are wide open during the relaxation phase. So you get the regurg. That's a prolapse due to disconnection of the leaflets from the cordon tendineae or rupture of the valve. Okay. All right, now back to prolapse. Mitral valve prolapse. Again, parasternal long axis view. Just looking here, first identify what's what. We got the left atrium, ventricle. All right, let's give it a play. Okay. So in here you can see the tricuspid valve is closed, so we know we're in diastole, and you can see the blue, which is the arterial blood, regurgitating into the left atrium. Wait, it is a prolapse. This is a prolapse. Let's see. Don't be afraid to change diagnosis here. I think that's the same exact video as this. Let's see. Huh. I think I just put the same exact video. No, it's showing different. I mean, this has to be a regurg. This is a regurg because a prolapse does not have a lot of regurg. What did we just learn? A prolapsed valve causes mitral regurgitation. So why do we have it different classification. Doppler echo prolapse. You can see some blue. I guess I'd call it a prolapse because you don't see a whole lot of arterial blood going back into the left atrium. But this is a prolapse with both leaflets. There's probably many types of prolapses. I suppose it's a prolapse because it must be spectral between the two, because you know it's a prolapse because you don't have a lot of regurgitation. And we know prolapse is a mild disease that progresses. This is just another picture of the flail leaflet, often described as a parachute with no strings. So when the mitral valve closes, like during systole, like a parachute opens, because the mitral valve closes as the parachute opens, and if it doesn't have the parachute string, it's going for an excursion, and that's a flail leaflet. Here is no flail. And why is it severely diseased? Why is a flailed segment severely diseased? Well, that's because it's not attached to anything, so you're going to get a lot. You're more likely to get over 60 mil contralateral jet flow. So this is an example of mitral valve prolapse that is severe. Usually the 8 million Americans that have it is not severe, but this form is. What I don't get, and you can mention in the comments, is why severe prolapse isn't just mitral valve regurgitation. I mean, it's a play on nomenclature here. This is, again, a severe prolapse due to papillary cord rupture. This is, so we are in diastole, and the way you can tell it's so severe is because you're in diastole, and this mitral valve leaflet is it's literally touching the bottom wall where the papillary muscle is. That means there is a complete rupture disconnection of the leaflets. If they're just going down to the bottom of the heart, that's a vacation. That's not an excursion. That's you're doing that. That's a 2-month vacation. Okay. Let's third main one. Let's move on to mitral stenosis. Remember opening snap. You can treat it with balloon angioplasty or surgical replacement, depending on the situation. And so, again, remember this calcification, anything that stiffens the valves. And you can see this is the weird one. This is the weird type of mitral valve regurgitation. Oh, and you know what? I just answered my own question because, no, I didn't. Never mind. Forget what I just said. So this is the opening snap. So you can see why is the regurgitation going into the left ventricle? Regurgitation and all the other ones goes into the left atria. And that's because um, that's because the because these leaflets, they don't want to move. Okay, they're stenotic. Uh, um, let's have a look here. It's stenotic. Don't confuse it with type 3B, where the leaflets have a hard time with motion during diastole. In stenosis, it's called stenosis because it's really hard to get them to open up during systole. So here we are at the very end of the relaxation phase, and you see all this arterial blood that's in blue in the left atrium. And because let's say you have a calcified mitral valve, and the pressure in the left ventricle at this point is the pressure in the left ventricle at this point is let's see. It's stenotic because the valves don't open all the way, so you have less blood flow during systole from the left atrium to the left ventricle, because the valve doesn't open all the way because it's and creates a stenotic valvular opening due to the calcifications. Yeah, and so this is where I said the opening snap is confusing, because you think logically the atrium is pushing as calcified, let's say they're calcified leaflets, and then they snap open, and that's what you think this opening snap would be. But it's actually in diastole. The opening snap is in diastole. So this is minimal, this is mild, and this is severe. And the best way to explain why it's heard in diastole is lub-dub. So lub is the closure of the atrioventricular valves, and the dub is the closure of the semilunar valves. So why did we ever call it an opening snap if the sound is created by them? It should be a closing snap. But you see here the stethoscopic sound is loud in diastole first, and then it comes down as it closes. That's because once you've popped open the mitral valve, the stenotic valve, it sort of so first of all, murmurs, you hear murmurs on a scale of 1 to 6. So let's first explain what a murmur is. And it's caused either by turbulent blood flow or by turbulent blood flow or turbulent blood flow. Anything less than 3 is not to be worried. Any murmur higher than 3 is when you should try to make a diagnosis. A good joke is grade 1 murmur is one that the cardiologist can hear without placing the stethoscope. A grade 6 murmur is one a cardiologist can hear without having a stethoscope on the patient's skin because the murmur is so loud. The disease severity is so great that you can hear it without the stethoscope placed. I don't know if it's true, but it's a joke. And a grade 1 murmur is so mild that, a grade 6 murmur is one a medical student can hear, and a grade 1 is one a cardiologist can hear. And a cardiologist, there's another thing where 6 is so bad that you can hear it almost with the stethoscope, not on the chest. But so as you go back into relaxation, the turbulent flow is more because the calcified valves they close slower. So you have turbulent flow at first as they slowly close until they fully close, and then you have no murmur. Now here in severe, you see the same thing. They're closing, but the stenosis, it's holosystolic, whatever, but not real. It's not technically holosystolic, but look at this. You hear the murmur throughout the entire diastole, and then it's louder here when it has to open. So that means that the mitral valve is constantly open because it's restricted movement, and the restricted movement doesn't allow it to close. That's severe. This is nothing. Mitral stenosis, you can see, as we spoke, the murmur is in diastole. Mitral regurg, holosystolic, because remember, regurgitation, all the types of regurg, they occur due to failed leaflets, so it's a continuous turbulent flow. And mitral prolapse is also similar. It's going to be in systole, and probably not as serious. They'll probably be less harder to detect. So here, if you look at mitral stenosis, the opening snap is the closing snap. I don't know. And that's it. Comments or anything else, please leave them, and I'd appreciate it, because I don't want to pass along information to. I hope my videos are useful despite their length, but I don't want someone to watch my video and learn a mistake and then a lower level, and then they'll keep that in their head for a while until they learn better. And with that, thank you for your view.